reason why we set these sessions up is really to like try and promote and get people using like the WSIC data, and we want people to do that because we understand that population health management is such an important part. So I'm going to share some slides, run through a couple of them, and then I'm going to hand over. So just bear with me 1 second. Thank you for recording, Rachel. Great. Hopefully everyone can see this. So this is essentially our running order of today. I'm going to hand over to Rachel in a minute just to give us a little bit of plan. We're going to do some context setting. I'm going to ask you a few questions around how you use the dashboards and the radars. Then we're going to go into a little bit more of a deep dive around some of these patient identifiable data sets and what we have. Hopefully by the end of today, we're going to have a bit more of an overview of why population health management and good data skills are important. And I think this is particularly in the context of the new model ICB blueprint that has come out and the 10-year plan. Also just reflecting a little bit back on sort of the last workshop, and the recording for that is available, as are some of the notes. And if you'd like to see them, I can definitely send out the links. They should also be in the invite to today's meeting. What we're also going to be hopefully have a look at is how using WSIC is effectively and impactfully is essential to like delivering on our methodology for delivering population health management. I'm going to talk about that in a little bit more detail really briefly in a second. We're going to look at what the radars are, how to access them, and how they help with that planning and decision making, and also a real sort of practical understanding of what support you need to incorporate WSIC into your day-to-day practice, what its tools and functions are, and who to go to for support. So that's what we were hoping to achieve by the end of today. Please let us know when we give us some feedback on whether we've achieved that. I'm just going to like take a couple of minutes really just to put this in context really. So part of the reason why we promote, as I say, the WSIC dashboards and sort of our fabulous WSIC, our data warehouse, it helps us deliver our population health management ambitions for the system. And when we talk about population health management, this is really around sort of reducing health inequalities, and importantly about reducing health inequalities by taking action, taking data-led and intelligence-led actions. And it's about using those data and intelligence insights to inform our interventions and to improve the health and well-being of our populations. And it's really about using sort of data for evidence, so that we're really talking about sort of when we're doing something, we know why we're doing it. There's really good evidence and the data supports why we're doing it. And again, it's around sort of using this to sort of serve our communities and recognizing that sort of the health needs of our community is only part of their needs, and that there are a lot of wider determinants of health, that it's not just healthcare. So when we talk about population health management, it's really around sort of a much more holistic approach, and it's about how do we sort of come together to make best use of those collective resources, and how do we work in collaboration with our communities. And this is a key thing around sort of making sure that we use data intelligently and we use it in collaboration, so that we get a full understanding of what the data tells us and what our community tells us. And it is about sort of like making improvement. Ultimately, that's why we are all here, because we want to make changes in a positive and impactful way for our communities. So there's something about sort of really understanding that sort of understanding and using data. It sits within the context of understanding population health management, why we need to collectively deliver that as we move forward. So the 10-year health plan and the new model IC blueprint, there's been other sort of like documentations and sort of like publications as well about the impact of making sure that we use good population health management techniques in order to deliver our services. And one of the ways that we want to support people with this is because I think having data in itself is really, really good, but it's about how do you use that within a context around sort of delivering your service. And what if you haven't seen this before, on the left-hand side here, this is our focus on methodology, and this is our approach to sort of implementing population health management. And what it does, it just gives us a structured approach to sort of delivering that population health management, and it helps us sort of find and analyze and describe the right intelligence and key components to delivering that along essential skills. So things like how do we work with our communities, how do we evaluate our services. So essentially, when we talk about sort of data within the context of focus on, particularly here, it's right at the beginning in the find areas of inequality using quantitative data. This is where the WSIC data really, really, really helps support us. Because if we don't get this stage right, we're going to really struggle to do the other areas here. So Fana, I can see that you've got your hand up. Was that an accident?
Now, I was just going to say that we're struggling with the slides a little bit. There's a lot of information on there. Any way we can put it on slideshow, or just zoom in a little bit, please?
Oh, I'm so sorry. I did mean to put it on slideshow and I neglected to do that. Apologies. Here you go. The slides will be made available. There you go. There you go. Sorry, that was my fault. So again, the purpose of today is to really look at sort of the WSIC dashboards and the radar. So I don't want to sort of spend too long on these slides. Very, very, very happy to sort of meet with people to like talk through the focus on methodology a little bit more, and it's like how we think that can really help us with our delivering population health management. But the key message around here is sort of, as part of this focus on methodology, it's around like finding data right at the beginning of the process. And if you don't do that, and if we don't do that collectively, we're going to really struggle to sort of understand how we deliver population health management. But again, really keen to sort of make sure that sort of we use data in an intelligent place, in the right place. So particularly here at the beginning of the process, use data to like really help understand and establish and identify your populations. And one thing just before I move on and hand over to Rachel was this is the second of our 2 workshops, and the first one we looked at the dashboards and how they can be used to sort of like support your work. And as part of that, we want to know sort of what it is that we can do to help support you use WSIC dashboards and the radars in your working practice a little bit more. And so there's been a little bit of feedback around sort of, well, it's difficult to integrate it into our day-to-day work, and we really want to sort of build on that and understand what that looks like and what it is that we can do to sort of really help that. There are, and Rachel McCarthy will talk about these briefly, around there are multiple existing guides and resources that can help support you, but we want to understand a little bit more what's that next step that we need to do to help to move us into sort of like using data-driven and WSIC-led approaches into your day-to-day practice. So please, when we send out the feedback, do let us know. There's an opportunity for questions and discussion during the day-to-day as well. And on that point, I'm going to just hand over to my colleague Rachel.
Hi everyone. Sorry for being late. I had Northern Line troubles. If anyone could go to menti.com and so you can use the QR code or go to the website and then enter the code, you can join the presentation, and I will just share my screen. Can everyone see that slide?
I can see it, yes.
Great, and I can see the numbers going up. So yeah, this is just to get a little bit of insight into what people know about the radars and how people are using them at the moment. So I will give everyone a minute to get going. Great. Okay, so well, the first question is just a bit of a warm-up, so it allows people to keep joining. And it's obviously probably the most important question that we'll cover today. So please vote for which puppy you think is the cutest. Hopefully this just gives people an extra chance to join and understand kind of how the Menti works.
Agreed, Rachel, all of them. It's an impossible choice.
Yeah, I'm forcing everyone to choose.
They are so cute, Rachel. You found the cutest ones out there, I'm sure.
Dog 3 is pulling ahead. It does look very soft. Yeah, it would be nice. Unfortunately, if we could actually have these puppies in real life supporting this talk, it would be even better, but maybe people wouldn't be able to concentrate. Okay, great. Thanks, everyone. So unfortunately, the next slide isn't about puppies. So I want to get your opinions about what comes to mind when we say radars. What do people associate with that? If they're using them, how do they use it? If they don't know what's going on, you can put that. Yeah, just your thoughts. Great, so interesting. But so data obviously coming out is one that lots of people associate with the radars. Obviously that builds up a lot of what's behind the radars and intelligence as well, but also detection and surveillance coming up as well as kind of key ones. Yeah, early warning, identifying risk. Yeah, these are all sort of things that the radars can do by using the WSIC data. Predictions, yeah, search data. Great, we've still got some people entering, so I'll give everyone another minute. Great. It's nice that we have intelligence coming out really big here, because I think that obviously means more to everybody than data. Data is kind of just numbers, and what do we do with it? Intelligence is actually something that gives us information with what to do. So it's nice that that's coming out. Okay, next one. So now just trying to get an idea of how often people use the WSIC dashboard, a WSIC dashboard or a radar, or even if it's not yourselves, whether you would like to, or it's your team that uses it, feel free to answer from that kind of team perspective as well. Yeah, actually, I might be connected now. Am I back?
Yeah.
Can people hear me?
Yeah.
I'm so sorry, everyone. Hopefully that's given everyone loads of time to answer this question. So yeah, it's really great to see that some people are using the sort of dashboards frequently, but there's also interest in using them more. Okay, so if you aren't using the radars or the WSIC dashboards, we're interested to know with what's holding you back from using them. Okay, and there's going to be a sort of a question later where there's more free text that people can sort of input the other issues that they're having, or any suggestions as well. Kind of looks like actually a fairly sort of evenish spread across some of the issues, although lots of people saying that they find the dashboards difficult to navigate, which is good for us to know. Great. Okay, thank you for answering that question. I'm going to move us on to the next question, because I think this is where we can really get some insights. So there are some supporting resources with the WSIC dashboards and radars. So we've got videos and different PDFs of how to use and kind of a guide. So what we'd like to know is how these can be better. So from what we have, how can we make improvements to help you use the dashboards and the radar? And feel free to be as descriptive as you'd like. And I think, yeah, if you hover over the title, you can then access where the materials are. Yeah, okay, that's really interesting to see some of these responses. So around sort of more workshops and interactive training. So I'm guessing that's maybe more in smaller groups, and sort of linking sort of data to uses as well. I'll just give everyone a bit more time to answer this one. I'm also sort of interested to hear whether sort of like these forums are kind of the best, or whether it's sort of peer-to-peer training that's maybe needed a bit more. Okay, yeah. Great. Okay, thanks everyone. I think we've got one final question. And this is sort of linked to the last one, but a bit more general. So what can we do to help? So what else can we do to make it easier for you to have data in your work stream so you can make good decisions from that information? And I'll leave this question open so people can come back to it through the rest of the session, and continue to put in answers of what they would like us to do next. I'll just let a couple things come through. Great, it's great to see some suggestions come through, and I think what I'll do now, so I'll leave this open, so please keep putting things in, but I'll hand back to Matthew.
Brilliant, thanks Rachel. I'm going to hand over to Rachel McCarthy now. I'm going to put the slides up. She's going to give
Matthew, I can share my screen if that's helpful. Yeah,
it's super helpful. Thank you, Rachel.
No problem. I shall do that. Bear with me one moment. Thank you very much, everybody. So I introduced myself at the beginning, but for anybody who joined a little bit later, I'm Rachel McCarthy. I'm the Business Analytics and Deployment Lead in North West London, part of the North West London BI team, but very specifically been working on WSIC for quite a number of years now. And today, so slightly different to the last session that we did, I'm going to be really focusing on the radar side of what we have in WSIC. So this is the patient identifiable, but I want to try to help everybody see the benefit, even if you're not a clinician and able to see patient identifiable data, but why it is useful to the services that you may support, so that we really can start to understand how this top-down approach of from a population, understanding our needs of a population, to then being able to identify the individuals and how this all links together. Following my session, I'll be working with Lindsay Williams, who's on the call with us, to go into a much deeper dive on a really, really positive example of a radar, which is the Frailty Escalating Risk Radar. Because it's absolutely excellent, and the way it's been implemented has worked really well. So I want a lot of us here today to understand how from the program approach, it has been able to be embedded and implemented in a really positive way and had a very good uptake. But first thing I wanted to do is give a bit of an explanation on WSIC as a whole. But for a lot of you, you'll have seen this slide before, but really focusing on how is this useful from a direct care point of view. So within WSIC, everything we do, we try to think of it from that direct care point of view. That's our number one purpose of having WSIC. So we can look at this from a proactive, reactive care. We obviously really want to try to establish a lot more proactive care use cases through this data set. So WSIC has a joined up data warehouse. It means that we get data in from lots of different places across the system. So we've got primary care, mental health, community, and so on. All this data gets linked up using the NHS number. And then we can provide that back in a number of different ways. So we've got all on the left-hand side here, these are our patient identifiable type of dashboards. On the right-hand side, this is our de-identified type of dashboards. In the previous session, we focused a lot more on this side. Today, we're going to look on the left-hand side a little bit more detail. So the patient identifiable dashboards are available to people who have a legitimate relationship with patients. That means you have the right to see patient information. And you can only see those patients' information that you have that legitimate relationship with. So if you work in a practice, then you get to see the patient's information for those patients who are registered to that practice. If you work in a trust, it works in a similar way, but to those who are being seen within your trust, as a North West London patient who's been seen within your trust or within that area of likelihood of coming to your services. It's all governed by, it's got a strict IG governance behind it, and it's all the access is given only appropriately and signed off by the organisation's Caldecott Guardian. This is to ensure that we provide the right access to users. So that to one side, which is all the, making sure that we're safe and secure and everything's being done by a legal basis. We can then think about that linked data that we have and all the opportunities that we can do with that data. So as this slide talks about the patient identifiable, we can look at this in a number of ways. So we can think about our case finding or case management use cases. So we might look at the integrated patient summary. So this is individual patients and an overview of all their activity going on across the system to really give us that holistic view of what's happening with that patient, not just from one particular point of view, but from everywhere where they've been involved. This includes health and social care information. We've got case finding tools. These might be things to do with risk segmentation or certain indicators that are not condition specific. So maybe having many A&E attendances or being newly diagnosed with a condition or having lots of DNAs recently. So again, different ways of being able to group patients. And then finally, we've got the long-term condition management tools. So this is where we think about the individual long-term conditions or problems, and then all the different indicators that might relate to that. So I'll go into that in a little bit more detail as we go along. Some of our population health dashboards, I just want to talk about this very quickly, because although this is over on the de-identified side, those people who have access to patient identifiable information from the pop health dashboards, you can sometimes drill down to those individual patients. So when we've talked about population health dashboards or the aggregate high level dashboards previously, there is use cases in place where if you identify certain populations where there is need and you have interventions that you want to put in place, but you don't know necessarily when you get down to onto the ground level who to contact, who are these individuals that we're talking about. Some of these dashboards will drill down to those levels, so you actually get to find out who those individuals are. But as I say, that's only available to those people who have that legitimate access to see that patient information. So our next slide here, again, for anybody who wants to know a bit more about this in detail, the previous session that we did that's on the YouTube channel. I've put the link in the chat. It goes into a bit more detail and it talks about all the data that we hold in WSIC. So it'll give you a lot more information about what we hold and how this all works. But I wanted to come back to this cycle of events to really focus on the act and interact side. So 1 through to 5 is all completed by the BI team. So we collate the data, we use the data correctly or link it up correctly. We then do the analytics on it. We do the visualization. We put the dashboards out there for them to be used. So the act and interact bit is where I really want to focus today, to think about how can we do that as best as possible. So what are our aims? What are our challenges to this? That leads me nicely onto this slide here. So for every single dashboard, we have a set criteria of aims. So every dashboard that comes in, every request that comes in, our team personally, we want to ensure that it will have the best success with the organization. And to ensure that, we have, the first thing we want to do is ensure that every dashboard has an owner. Okay, there is a program, say the CRG in the ICB, or the HIU program, or Frailty. It's these people who come together, and at that program level, they take ownership of what that dashboard will be. What's its use case? What are we going to be putting on there? What's going to be useful to us? What information do we need? And how is it going to get used? How are we going to ensure it gets used? How can we support our users to use it? All those sorts of questions. So it's really clear, it's really key to establish the understanding of what the dashboard will do for the program. A dashboard alone will not make a difference. It is an enabler to a wider framework. So when we look at these things, we really want to get an understanding of what is the framework around this. If we put a nice, pretty dashboard together, that's lovely. But quite honestly, the people who will look at it and use it are those who are probably quite data savvy or just interested in doing something very specific in that area. But on a wide scale where we want to make the biggest improvements, we really need to understand and make sure there is a framework around this. So dashboard really is one element to a really good outcome. We've mentioned about the use cases. Again, that's really key to understand at the beginning before development. What's the dashboard for? We want to make a dashboard that has a purpose. So if we don't know what the purpose is to begin with, it won't necessarily meet a specification and have a good outcome at the end. We want to be able to know what we're trying to achieve at the end, so we can measure that benefit. So if we want to make an improvement in health outcomes, which health outcomes, how can we see that changes? And like I said, dashboard alone will not make a change. The framework around the program will make the change. Having SOPs or documentation in place to help users on how to use a dashboard, what to do with that information once they've got it. Really, really good. That makes a big change in how to use that. And I think that links back to what some of you were saying on the Mentimeter about saying you need more role specific training or area training. So through the program or through your boroughs, having that local SOP or documentation say, right, once you've used the dashboard or how frequently you should use this, when you get that information, then you've got all these different options and a bit of help to say how you can then do something about it. Engagement strategy for every dashboard. So again, this is something that we've done really well with quite a number of the programs, where once a dashboard is created, there is an entire plan driven by the program on how to engage with all the expected users of this information and to really link it into how to use the data to move forward, how it fits into the framework. So it's really quite clearly links across. So our challenges that we have, we've got a lot of dashboards that have been created with good intentions, but hasn't been adopted at scale and usually because some of these aims on the left-hand side have been missing. Sometimes dashboards can be quite complicated or busy. So I see, like a number of people mentioned, it's difficult to navigate a dashboard, don't know quite how to get the right information out of it, that sort of thing. So what we do, or what we want to do, is to help improve on this challenge, to make things a little bit better, is do a regular review with the owners of the dashboards to say, is it fit for purpose? Is it getting what we need out of it? So are we actually seeing those outcomes, those benefits? And if not, how can we improve the dashboard to make it easier to use, to make sure that those outcomes are being realised? The BI team alone cannot drive engagement. It is quite a challenge. And where we see it work well is where the programs are fully engaged with us. We don't work alone, and we don't expect programs to work alone either. So this is a combined, a co-approach to driving engagement, and that seems to work really well. So that's where we've seen the best pieces. So if we're ever working on a new dashboard or a new use case, it is key that we have that working together scenario. So either through the borough teams or through the programs directly, working on an engagement approach jointly will have a much better outcome than BI or program trying to do it alone. So what is a WSIC radar? It's quite a difficult one to describe because we use them in so many ways. But essentially, the purpose of a radar is to be able to visualize patient lists and their key metrics associated with that specific condition or problem. It can also help clinicians identify patients who may need intervention either proactively or reactively. As I say, we're trying to really focus on the proactive side, but you know, reality is we do a lot of reactive work as well. We've got the patient list view. So with regards to this, is to say, how do we decide who those patients are on each dashboard? And we determine who that cohort is will depend on the requirements for the dashboard. So if it's an asthma dashboard, we would use the QOF asthma business rules to define who's asthmatic. HIU, specific logic there around having 6 or more ED UTC attendances in the last 6 months. For frailty, it's your EFI score, so excluding those who have a score of fit, so your mild, moderate, severe patients. So there's lots of different ways of being able to, out of the entire WSIC database, saying who is it, what's the cohort of people that we want to see on this patient list. And then once we've looked at that and we have that cohort, then to say what individual metrics would go with each dashboard. So if we're talking about asthma again, we might want to look at asthma specific prescriptions, number of exacerbations, that sort of thing. So there's lots of different specific metrics depending on that condition or problem that we're looking at. And then finally, on every dashboard, there's filters or segmentation tools. So the dashboard isn't fixed as it is. You see the patients on there. The data does get refreshed on a daily basis now. I think there was a question about that earlier, but that's now been brought right up to date. So it's a daily refresh now. But not only that, there's a number of filters at the top, which will allow every user to slice the list down to a more specific cohort that is more local to your needs. Okay, we know across Northwest London, there's no one size fits all. But so we allow this sort of, if you're very interested in those who have also had multiple exacerbations or been seen by certain providers, that sort of thing, it allows more narrowing down that cohort to something that works for your local needs. There are quite a number of different patient identifiable dashboards in WSIC, and you'll have seen probably this list before, but it's different. And as I've mentioned, that's because we do this piece of work to ensure that dashboards are fit for purpose. They're still relevant. So we've had dashboards, we've got new dashboards on here, we've got dashboards that are no longer on here. So there's a constant review with the programs to ensure that what we are providing has a use case and is fit for purpose. So we've got on our patient selection. So these are dashboards that aren't condition specific. And we've got watch lists. We've got the patient radar, list maker. So this is a very open dashboard that gives you lots of options. It just gives you all of your patients that you've got access to, and then you can select a number of different filters to it. And then there's the risk segmentation dashboard. So in Northwest London, there's we've created a Northwest London risk segmentation. This is, when I say we, I mean as in the whole of Northwest London had a number of clinicians and public health colleagues involved in creating that risk segmentation. So there's this dashboards for adults and CYP on that. Now, under long-term condition, we've got a number of different radars here. So we've got the AF, asthma, diabetes. We've got a frailty care and clinical radar. That's not the one we're talking about today. We've got COPD, mental health, learning disabilities, dementia, and the frailty escalating risk radar, which is the one that we will look at in more detail today. That's our newest radar out and available to everybody, literally in the last couple of weeks. It's brilliant. So we will definitely use this one today to go into a lot more detail. We'll show you how it works. Lindsay's going to give you a big overview on how did we get to this point and why it's working well. And just as an example, when I talk about radars, they can look a little bit different. You'll see, though, there's some similarities. We've got patient identifiable information. So their name, this is all demo, by the way, just in case. But we got their names, their age, and then some additional factors. We'll see that quite consistently across each dashboard. But then when the metrics come in, this is where we might see a slight difference in how the information is displayed. But the principle is the same across each radar. So you get that information about who are we looking at, and then a list of the different metrics working from left to right. So just finally then on to what is it that our business analytics and deployment team provide to help support you. So for all users, whether you are a patient identifiable level or you look at things from a population aggregate level dashboard point of view, we have user guides for every dashboard. A user guide will include the purpose for the dashboard, an introduction to the problem, and how to navigate through the dashboard with screenshots, and then a section at the end which is to give everybody the opportunity to see how is it that we pull that data together. Where does the data come from? What coding do we use? What logic do we use? Is there any color coding involved on the dashboard? What does that mean? So that's all available in the user guides. For every dashboard, we also have a video which will take you through how to navigate and to access certain parts of information on the dashboard. So it'll give you lots of ideas of how to use the dashboards or the different dashboards. They're all available on our YouTube channel. We do QRGs, quick reference guides. So we work with the programs or the owners of the dashboards to understand what are the use cases, the key use cases for this, so we can help make a QRG. A QRG is a 1 to 2 page quick guide on how to do something very specific on the dashboard. So if you've got a use case where it is to select a certain criteria of patients from the dashboards and you don't know which filters to choose or which order to put things in, then these QRGs will tell you how to do that. But as I said, that's driven by the use cases from the program or owners. So we will work with them on that. If anybody has any ideas on what you'd like to see on these things, and you think, oh, there's no QRG on that, something I'd like to see, speak to your program. Say, this is something, one of our key use cases. Is it possible that we can get that? Make sure that's documented. So then program will speak to our team and give us the list of those sorts of things that are required to help support the uptake of the dashboards. Every dashboard has a code set, so there are lots of different codes out there, and it can be very daunting to think, how do I know if I'm recording the information correctly so it will show on the dashboard correctly. So we do talk a lot about standardization across Northwest London. If everybody's doing something and recording data differently, it can mean different things, and it's very difficult to then show the right information then on a dashboard for the same questions to be answered. So we ensure that we publish all of the different codes that are used, so that it's very transparent as to how this data is collected and then presented. And my team will work with people directly where it's been identified there may be a problem, whether that's because data's not being recorded or whether it's because we're not capturing it correctly. It doesn't matter. We will always work through every sort of issue like that to get to the bottom of it and help then provide a solution. Great. I'm going to hand over to Lindsay. I can keep sharing though, Lindsay, if you would like. Yeah, you're on mute.
Yeah, that would be great, actually. I did get my slides ready, but yeah, if you are good to share and you're stable on that, that'd be perfect. Yeah. So brilliant.
Thank you.
It's gonna be a bit of a tag team between us both, because I'm going to get Rachel, because Rachel has access to the visual of what I'm going to be talking about, but without me sharing patient identifiable information. Otherwise, I would share my dashboard, but then you would see patient identifiable information. So I will be handing over to Rachel again at some point in this. So just to introduce myself again, so I'm Dr. Lindsay Williams. I am a GP in Northwest London. And for those that do know me, I am the palliative and end-of-life care lead for Northwest London. However, because of the work that we did in Brent, when I was a clinical director in Brent on frailty, I've been pulled into supporting neighbourhood health and frailty. And that's where we developed this dashboard, which now all 8 boroughs have access to. And this is the escalating dashboard. You did see on Rachel's previous slide, there is another frailty dashboard. I am going to talk to that dashboard because that's non-identifiable information, but there's more work that needs to come with that. So at the moment, we haven't got a population health frailty dashboard that's accessible to everyone. It's something that we are looking at and wishing to develop. But what we do have is this risk escalating radar, and it gives you an idea of what WSIC can do and where you can take it with the right case for change and what you're trying to do. Next slide, please. So I'm going to touch on these 3 areas. So one is the WSIC Frailty Risk Radar, what it is, how it was developed, how we use it, and then I will talk about the population health dashboard very briefly at the end, which we don't have access to at the moment across all of 8 boroughs. Next slide, please. So firstly, Rachel talked about this. We know that WSIC is this data warehouse that pulls in data from across the system. We're really unique. We're the only ones in the whole of England that have this type of data. It's available to all of our 8 boroughs in Northwest London. And for this specific risk radar, what we wanted to do was optimize stratifying frail patients. So at present, there was, well, I think it's gone now because it's been replaced by this, but there was an older dashboard, but it really only looked at those with electronic frailty scores. It was very focused, and we thought, we have all this other rich data from across the system. Surely there's a way we can pull it into this dashboard and not just limit it to the data that we have. And that's where this focus came from to develop this dashboard. So it was a real, we think we can do better with identifying frailty and stratifying frailty in Northwest London. So we took the case to WSIC, and this is how it was developed. So it was from an old one, actually, and then we built on it to really build that opportunity to really see the patients that are at higher risk, and that are more likely to have adverse outcomes. So this new one gives you a much quicker identification of the patients in the higher need of targeted support. It helps you think about what type of targeted support, and then it gives you an indication of where their rising needs are most prominent. And the idea is that this really focuses on the needs. So this is the difference as well. We're really looking at that full 360 need of the patient as to how we've developed this. So next slide, please. So it's a bit of a busy slide and I apologize, but I wanted to explain. So what we start with is a frail population. Okay, that's your baseline. But then what we originally were doing was just calculating mild, moderate and severe frailty. And that's fine. That, you know, it works, and most other areas in the UK use that, and that is great. We have so much rich data that we have enhanced that. And this is where we've been able to really focus on, right, so we've got this frail population, but are they at higher risk of admissions? You know, we all make those assumptions. We in WSIC, we have the data. We can see that they're at higher risk of admission. So we can categorize that. So you get this frailty score crossed with the risk of admissions. Now, this gives you really helpful data in identifying those patients of, right, these top patients, these are the ones, if we focus on what their needs are, we're going to be able to improve their outcomes. So you can just get a vision of just that much more focused area of support. So, you know, so initially you get that full cohort, but then you just start to divvy it down. So the next slide shows you that we start with the baseline, but then we added in some other factors. So the high risk factors, they're under the precipitating factors, the high risk ones. So admissions, and we've put that admissions related to frailty, your falls, and immobility, your delirium, your incontinence. Admissions in general are good because, again, you know, not just related to frailty, you know, they just are more likely to be admitted. Falls on its own, we've collated as well. And you can see we've given a percentage of how we have included these risk factors. Attendance is an A&E, and then you've got your referrals as well. And again, you wouldn't get this data anywhere else in the UK this easily. But we have this data warehouse that pulls all of this data from across the system. So we're then able to make these decisions on what goes in to really help drill down and make it much more relevant on the impact of frailty for the patients. And then we also have the cofactors. And again, these were quite interesting because they're not included in the electronic frailty score nationally. But things like social isolation, polypharmacy, DNAs, dementia, and mental health, all of these are going to contribute to a patient becoming more at risk, but particularly when paired with frailty. And so we added in some of these. You can see they're small percentages, but they're in there. And then the dashboard allows you to cipher off these cofactors and these precipitating factors. If there is something really specific that you know you would like to focus on in the borough, or you know you've got something going on in the borough, this is how you can really start to see, right, who is it? Who are these people? How many are these? How many have we got of these people? So gentle reminder, this is the patient identifiable risk radar. So it would be those with a clinical legitimate relationship with the patient. It's something that, you know, you can ask clinical colleagues to run as a program lead, and they could give you, you know, numbers. They don't have to give you the exact patient, because that really helps us deliver the care. But for the system and for programs, you could get numbers. And I will talk about the population health dashboard, which ultimately, you know, it gives you those whole population numbers, which is much more helpful from a program and system wide. But there is nothing stopping you from working with clinical colleagues, and that's the idea at program level, is to work with your clinical colleagues to support. Next slide, please. So you can just see how you can optimize and build. Now, with any tool, we always say, with anything with patient identifiable information as well, there's caveats to it. It's never going to be perfect. Remember, it's pulling codes, and not all coding is appropriate or adequate or correct. So I always keep that in mind. And so a lot of this, when you're looking at patient identifiable information, does need some clinical ratification. So it will need someone clinical to then go through and go, is this relevant? Is this appropriate? We have ciphered off patients where we've got multi-organ failure, end-of-life palliative, severe mental illness, and under a care plan for mental health. And these, again, they're not going to be totally excluded. You can add them back in, or you can remove them again. So that's the thing. I know that these dashboards look busy, but if you know how to add in and remove, then it makes it so much more valuable for you to really see which patients can benefit the most, because you're hoping, if they're end of life and palliative, which is my bread and butter of most of my day job, is that they would already be on my dashboard of the end of life care dashboard, and they would already been supported and picked up elsewhere. So they should already be under XYZ. However, that may not always be the case. So you get this whole total population idea, and then you can cipher off. And there is future discussions. Again, this gives you an idea of social circumstances, safeguarding. You can, with the right case for change, you can build in really whatever you want to really make this matter. Next slide, please. So this gives you an idea. So at the very top, that was what we used to do. And so we just used to do frailty, mild, moderate, severe, a traffic light system of, green, amber, and red, and just focusing on the National Electronic Frailty Score, which is great. It's been nationally ratified for years. However, we in North West London have WSIC, and this shows you, Rachel had it in her previous slide, but you can see the data sources. So you can see we're getting SUS data, GP data, ECDS data, and these were what we started to pull in to our risk radar. And it shows you what you can do. So I really wanted it just gives a great example of what you can achieve and how you can improve the data and make it more specific, make it more valuable to you, make the intelligence helpful for you in whatever then you're wanting to progress. Next slide, please. So access, Rachel talked about. So access to the dashboards needs a submission to WSIC team because this is patient identifiable information. If you were looking at population health, correct me if I'm wrong, Rachel, they don't need to go through WSIC for population health, or they do?
They do, but no clinical, no guardian sign off. That's the
lovely
difference.
Yeah. Okay, all right. So everyone needs to go through WSIC to get access, but if you want patient identifiable information, you do need to show a legitimate clinical relationship and get support from the Caldecott guardian, who's data protection for your for the organisation. So we've got the link there, and then we also, of course, we have that single sign-on. So then once you're in. So then it helps you. You don't have to keep logging in and out forevermore. And then you just have access to that, boom, all the dashboards together, and then you cipher off which dashboards you want. And please do make use, I should have put a link for the YouTube channel. Do make use of the YouTube channel, because that is really helpful, because I find watching the video, then pausing, and then opening the dashboard and looking at it is a really useful way to build confidence and knowledge in using it. So that's how I do my learning with the WSIC dashboards, because some of those, I was jotting some down on my CPD actually, because some of those I was like, oh gosh, yeah, I don't think I've ever looked at that dashboard, but I would like to look at that dashboard. So it just goes to show that sometimes you're only really focusing on the ones that matter to you, but it actually really is helpful to know that there's lots of others as well. The next slide, I think I'm going to talk about the population health. Yes, so this was the other dashboard that Rachel mentioned. Now, when we developed the risk radar, which is now available to all 8 boroughs and has patient identifiable information, we also thought we do need a population health overall dashboard, but also to look at population outcomes based on frailty services and frailty support. And so we, in a crude form, we developed something. However, looking back at it now, it does need some more ratification. It is available to Brent and Harrow, because that's where the first risk radar was created. But it's not available across all 8, because I think that there's more work that we need to do to make this information more relevant. We need to work with our health inequalities team, and we need to look at overall health outcomes specific to frailty. And I think that at the moment, it's not quite perfect, and it just needs a little bit more work. So there is something that we hope is coming. In the new year, we're going to be discussing at North West London ICB level about developing this, because I think that it has got legs and is necessary. But at the moment, it's the risk radar, the escalating risk, which does need that clinical element of support. However, there is nothing stopping a programme team working with a clinical team to support you in the numbers. They don't have to share patient identifiable information, but they can certainly give you numbers of what that risk radar is looking at and the areas that it's picking up, and the co-factors and the precipitating factors. And that gives you golden information at a neighbourhood health level. So this is, I'm really focusing on frailty here, and that's not the point of this session. It's really about WSIC in general, but we wanted to give an example of what you can do with the right focus and the right cases for change. You could develop this, depending on what your neighbourhood is looking at. And then I think I'm going to Rachel Mack, who's going to then do a demo, so this is the demo system. So I don't have access to this. I don't think I do anyway. No, no, I was going to say, I don't think I do. But I have obviously my patient identifiable information. So Rachel, just show us. So you did show us some small snapshots of this previously.
I did. But I want to give just a minute at the beginning to explain how we get to all these different dashboards that we've talked about. And we'll use Frailty to go through as the demo. So for all the users who have the patient identifiable access, this is the first screen that you're presented with when you log in. Now, you may have saved the URL for a dashboard, that the one and only dashboard that you're interested in, which is, really helpful to a lot of people. But if you're here to look at maybe one or the other dashboard, or you just want to know what's available and have a look through and how to navigate it, this would be the screen that you come to. This is our home screen. Okay, we've got 3 areas on here, and I've mentioned these in the previous part of the presentation. So we've got the patient selection, and this is where we saw the things like the watch list, patient radar, the risk segmentation, etc. Then we've got the long-term condition management. So these are the LTC dashboards, and then the population health. So all the population health dashboards are available to these users too. And as I said, some of these therefore can drill down to that patient list view as well. I'm going to focus in on this long-term condition management piece here, because this is where the frailty risk escalation dashboard is. But you can see here we've got all the other different dashboards available too. So once you click on the big blue button here for long-term condition management, you then click on the frailty risk escalation. And what it will do is it will take you to the dashboard then. So it's 2 clicks there. From here, users who have access will only see their patients. Okay. So if you work in a practice, you'll only see patients who are who have an EFI score of mild, moderate, or severe on this dashboard, who are registered at your practice. Okay. You have their name, their NHS number, what that EFI frailty classification is for each of them. Okay, and then these next 3 sections across left to right are the specific metrics relating to this dashboard. So this is the bit here where we worked really closely with Lindsay and team to understand what the requirements were, what metrics do we want to look at, what colour coding do we put to each metric, does it have a colour code, You know, all these sorts of questions had to be answered next. And one of the additional bits, which Lindsay, you gave us loads of detail on just now, is the Frailty risk score. So this is developed through the programme, and the logic to this risk score was given to our team. We then created that in the back end on the data, and then tested that back out with the test clinicians and the programme to ensure that it is displaying what we expected to see. So once you're on the dashboard, what can you do next? Along the top, these are all these different filters that I've mentioned. So each individual have the choice of slicing this list down further to the criteria that is useful to your local area. So if you have, if you're working in an INT, let's just pick one as an example, you'll just have access to the patients who are registered to those practices within that neighbourhood team. But you might want to then focus down on just one practice and see which patients relate to that. This is just showing you how the dashboard can change, how it can filter down. In a lot of cases, this is all going to be pre-selected for you. If you've only got access to one practice, this is how it will show. You will have nothing else to filter down here. Provider. The provider filter means of these patients, who is their main provider? Who are they known to? So in WSIC, this is the acute providers. In WSIC, we are able to see if a patient has had inpatient, outpatient, A&E attendances, those sorts of things. And again, working with our leads in the acute providers to understand how would we know who would be maybe seen as a main provider for a patient will depend on their current activity within that provider. So if they've got an ongoing outpatient episode, then that would be one of the very highly weighted pieces to say that they'd be seen by the main provider. So maybe take ICHT as the example, choose that, and then we're filtering down our list further again. EFI, because we're looking at our mild, moderate and severe, part of like the local requirement might be that you just want to focus on your severe EFI patients to begin with. Okay, that might be your first step to really get on top of like the case management point of view, like who is your most severe EFI patients, your frail patients, to that classification. It may be that use case changes over time, where that becomes, and it is probably in a lot of the frail teams already, that you already know all of these patients. This is not new information to you. So you might actually be more interested in those who are moderately frail and choose that list instead to help just narrow that list down so that you're not there with a huge long list and you don't know where to start. We've also got gender, ethnicity and deprivation. So deprivation is based on the decile. So 1 being the most deprived and 10 being the least deprived. In this scenario, because of all the filters I've added, these are the deprivation deciles that are less. So our most deprived area would be a 2. So anybody who's living, who is moderately frail, known to Imperial, ICHT, NHS Trust, and living in the most deprived area. We've also got our age band filter. So we could look at our older people or our adults. We've got housebound. If they're housebound, we could select that as an additional filter to understand those who aren't able to get out and about. And as you can see now, the list is getting really quite short. We've also got a specific filter in here for the exclusions, inclusions. And this is, again, driven by the programme for some very specific metrics for this dashboard. So do they have multi-organ failure? There's no exclusions present for the patient, or they're in a nursing home or have palliative care, end of life care in place. So there's some additional inclusions, exclusions that you can add in. And then finally, we've got the sort the table by. So if you've got quite a long list and you still want to see, you maybe want to sort it by those with the highest frailty risk score, or those who are known to social care or have dementia. So you can start changing the order of which you see those patient lists in there. So by clicking just above each filter, I can remove the filter. So if I want to remove my deprivation filter, you see there's a little filter with a red cross above it. Click on that, it will move that filter. You can reset all filters on every radar by clicking the reset all filters, and that will do the lot all in one go. Quite quick and simple to do that then. So I'll show you if I change the sort now. So if we see we're sorted by the frailty risk score, so those who've out of the logic that Lindsay presented to us earlier, there is not just the EFI frailty classification, but a risk score as well. So this helps using all these different metrics to give a weighted risk score for that frail population. So if I didn't want to look at it by the frailty risk score, I could change it to find out those who I want to see, all those who've got dementia, which I don't have anybody on my list. That was a poor choice. But maybe those with the most referrals, for example. And then we can see that list will change there. Now, each one of these, we will see as we hover over it, sometimes they give us a little bit more information. So in this case, you know, this is a non-elective hospital admission for this patient. We can see that the event date, when did it happen, when were they admitted into hospital, and what was the frailty syndrome. So in this case, it was a fall. We've got other non-elective hospital admissions, falls. This would just list all the falls. So if they've had multiple falls in the last 12 months, it will list all the dates for all the different falls that they've had. And we can start seeing whether this has become more frequent quite clearly, quite quickly for that one individual. So if they've had multiple falls, we can see when they have happened. A&E attendances, so when were the last A&E attendances for those patients? Referrals, not only when were the referrals made, but to which departmental service. We've got the number of GP contacts in the last 12 months. Are they a London Ambulance Service frequent caller? Social isolation is basically, there is a SNOMED code to say that somebody is socially isolated, but we also have a logic that say that somebody might be socially isolated. So there's a number of indicators that suggest that, because maybe a death of a spouse or something like that would indicate that somebody may become or is socially isolated. So there's indicators for those there. Polypharmacy. So this is just to say how many different prescriptions somebody has. Do they have an SMI? Have they had DNAs to hospital appointments? Do they have dementia? Are they known to social services? Multimorbidity. So if we hover over these ones, we'll see what other long-term conditions these individuals may have. Known to the enhanced frailty service. So this is something I was speaking about a bit around the framework. So across Brent and Harrow particularly, they've worked on this enhanced frailty service, and a lot of the boroughs have frailty teams in place, and around this framework, this dashboard works really well. So from a practice point of view or an INT point of view, all these patients, you might think, well, hang on, these individuals need specific frailty care, and it would be good to know if they're known to that frailty service already. So that's where this indicator becomes really important, to understand if they're already known to that particular service. Known to the rapid response team. Do they have a carer, or are they a carer? Two different pieces there, but very important to understand from that, again, that care point of view. The number of care plans that are in place, and are they in date? So you see this person here has a care plan in place and it's in date, it's green. This person here has a care plan in place in date, but it's unspecified, recently done, it's in amber. So we've got different, and again, these off the surface, it's quite difficult to say, hang on, why would one be amber? Why would one be green? Why would one be red? And so on. But in the user guide, it splits all that out and explains all the different logic for those things. But in essence, green is good, amber is a warning, red is not good. We're expecting to have care plans in place for these patients. And then we've also got the universal care plan. So if that's in place, if it's coded on the in the clinical system to say there's a universal care plan in place, it will show up on here as well. Right, that's the demo of the dashboard, but I wonder, Lindsay or others, are there any particular things you'd like to see on there while we've got the time?
Thanks, Rachel Mack. I've just been answering questions in the chat, and actually, yeah, I was going to say I assume there might be some questions on it. So actually, I'll open out to the floor as well. But let me know if I've answered your question in the chat and you're not entirely clear with the answer. Do put your hand up as well, Ben.
So I'm just looking on it on one of my GP practices, and it pulls up 1,000 patients for a practice that's got about 5,000. So I would want to narrow that down for my teams to get, you know, the top 100 patients who need proactive care to keep them out of hospital in the next couple of years. What would I do with my filters, and how would I rank them to get a better list?
Okay, so you've got this at the top where you can select things. Okay, yeah, so there. So number one, actually, I was going to say, Rachel, is patients to show is you can select 100 patients to show, number one. So if you only want 100, then only do 100 patients there to show. And then you start looking at how you want to sort your table. So if you want to sort them by because I assume ethnicity, deprivation, age band will keep the same. So you can then decide. So if you're looking at a totality of frailty risk score, which is the electronic frailty, which we all use, plus all of these precipitating factors, that would be the top bit. It's this new frailty risk score that we've developed in North West London using WSIC data. So I would do your top 100 patients to share, select that one at the top, and that is how I would focus on for your patients. If there is something specific that you really want to look at, like falls or another element, then select one of those. But ultimately, your frailty risk score is the benefit of this dashboard and not something you're going to get from running a System 1 or an EMIS search. So that's the difference. And they're your patients, is that top list. And just focus on the top 100. Because, yeah, the idea is, this is why it's such a unique dashboard, is it's going to include all of your population. And then you can then drill down to that frailty risk score, because you'll see, using that mild, moderate, severe, actually, this is a much more specific way of identifying these patients. And yes, Selena, you said if the coding's not accurate, is the dashboard still useful? It's like anything, any search that you run in EMIS or System 1, it's always as good as the coding. But as Matthew commented on earlier, by knowing that we have these dashboards, we're hoping then that people will take more care and attention to their coding. Of course, it can't be perfect, but that's why we recommend templates, for example, when looking after specific cohorts, because those codes in the template in Northwest London are linked to these dashboards. So that's why when there's a specific template, a lot of thought has gone into developing the template to link it to the dashboard. But you're absolutely right. A dashboard is only as good as the coding. Radhika, nice to see you.
Thank you so much, Lindsay and team. It's lovely to see all of you and to actually go through this presentation. This is a fantastic resource that we've got in WSIC, which is free of charge. And it has been actually simplified for us to use now when compared to when it started, about 10 years ago or so. Now, I'm just thinking about the evaluation and also the practices you've been using it. Is there something that we can do to bring them here and for them to talk through, what they have done? What's the benefit that they have actually, got? Is there something that you could provide us as case studies, especially for frailty and especially for reducing hospital admissions, like the previous,
That's a really good idea. I really like that. I don't know, Matthew and Rachel C, if that's something that you would like to bring here to a future webinar, because I do think that sort of case of how we're using WSIC dashboards in neighbourhood health, in whatever you're using, but specifically neighbourhood health would be great. Matthew, I'll let you come in. I don't know if this would be the place, but I really like it, and I think that's important to do.
Absolutely, Lindsay and Radhika. It's a great suggestion. the whole point of this is this is such a fantastic resource. We really want people to use these. We really see the value in this. We will do whatever it takes to get people to sort of pick these up and use them. So we're very open to sort of whatever suggestions. What's the best route for us to be able to take this out and share the message, and sort of, we feel really evangelical about these because we know that they have impact. They're really, really good, and we want to share that. So tell us the best way for us to do that. If it's through use cases, if it's through coming through to teams and sort of doing specific, like, look how this works and this is what it's done. We're very, very, very happy to try and put as much resource within the limited resource we've got towards that, because I think it's really important. So absolutely, we're very happy to set up some more workshops. We were discussing yesterday as part of the planning for today about sort of actually what will the next steps after this session be. Some of it will be to sort of go through all the feedback that you have very kindly given to us and understand what needs to happen from that. But the next thing, absolutely, if it is around sort of taking this out a little bit more, developing use cases, really sort of pushing forward with getting this used and embedded and understanding how we can support people to do that, absolutely. So workshops, we're very happy to set them up and sort of describe that in a little bit more detail.
Thank you so much, Matthew. There's also actually, Simon has written which is part of the evaluation itself, which is actually looking at using WSIC, does it make an improvement or not? And I think we've got some case studies to prove that. Probably, we need to actually, go into it in detail. Thank you so much. Thank you, team.
Back to Ben.
Sorry, very excited about this whole thing. So when I've used the other WSIC sort of dashboards before this one came along to try and find the patients with really a good opportunity to keep them out of hospital in the next few years, and I've then taken them back to GPs, and sometimes I've had varying responses from the GPs about how useful the lists are given what they know about their patients. So I'm wondering whether you've tested this with GPs and said, here's our WSIC best guess as to who you need to focus on to keep your patients out of hospital in the next 12 months. Do you recognise them? Are there people who are, top of your list who are missing?
Absolutely. So when this was developed in Brent and Harrow, it went through a number of practices to cross-check that, because it's going to need, I think in one of my slides I put clinical ratification. It needs to have that clinician who knows the patient, who goes, right, no, that's actually not the right patient, and probably this one. I do the same with this list, also with my end of life dashboard. I'm constantly cross-checking that and going, no, that patient, I don't know why that patient's there, but actually this patient should be there. So it needs that clinical ratification. It has gone through that in Brent and Harrow, which is how we know that we've kept this same logic and rolled it out across all of the others. Hounslow are also doing their own user testing, again, because they were developing their own risk frailty strategy, and now they've come, they've got this, so they're going to cross-check that with that. But really, it needs that clinical ratification. This is not this is it. This is the number, guys. It needs that clinical ratification of are these the right patients that you feel are relevant and that we can support. So that's why it needs that. So I always caveat with clinical ratification, and this is not just that's it. This is the number that you use with all of these. And as we've talked about, mainly because of coding and pulling in that data, and then just knowing the patients and knowing why they've had X number of activity. And actually, it might be totally relevant and appropriate for them to have had X number of activities. I do see that a lot with some of our frail patients, and then it stabilizes. Oh, sorry, I've just seen someone else got their hand up and I can't see your name. Mitch. Come on in.
Hi, folks. Hi. Thank you so much. Lindsay, I'm terribly impressed. Really impressed with what you've done with this particular dashboard. I just wonder, I really want to ask about the focus on methodology, because the focus on is about seeing some change in the current status. Indeed. And I wonder where you see, how you see the dashboard being used to look at before and after.
Great question. So the risk, this is where that second dashboard was developed. And it's the one that we just have in Brent and Harrow at the moment. And that's our population health and our outcomes dashboard. That's where I would like to see the outcomes for these patients improving. And that's what we need to do a bit more work on. It's very crude as it stands at the moment. We have I have a user guide for it, which I can happily share. You just can't use that dashboard at the moment. But in the new year, I'm really pushing for us to develop that, because yes, it's all well and good having this list and doing what you're doing, but how do we know that it's making a difference? I completely agree with you. It's really hard to see on this unless you run it, you risk stratify it, and your risk stratification moves. So the people in your top 100 or top 50 or top 10 shift potentially is one opportunity, and that's how at the moment I'm suggesting to use it. But that second dashboard is really where it's at, and that's why we do need, and really I want to pull a task and finish group together for that to support us in, because it's crude at the moment. It's there, but I don't think it's that help. I don't think it's delivering on what it needs to for Brent and Harrow. They use it, but not as much as I think it has the potential to. And the WSIC team would agree, and the health inequalities team all agree. So there's more to be done. It is going to need a little bit of investment to be able to do that for all 8. But I think that's where you get that opportunity for neighbourhood health, is for our colleagues who don't have PID access can then use that as an opportunity to say, right, where can we target? Where are things heading? Where can we put in place certain things, and cross-check it against the risk radar? Go to their clinical colleagues and say, look, we've looked at the outcomes dashboard. Does it reflect in yours? And have you got an opportunity to make those changes? So I think the two are needed together, personally. But it's something that, as we know, money is stretched, resources stretched, but we did get to roll out the 8 risk radar, which is great. So this is new and exciting for everyone. But that population outcome dashboard is really where it's at, to really check, are we making a difference? Is what we're doing improving the needs of our population? Is it addressing those needs or not? Is it just tick box? We're doing it. It's not an activity dashboard. That's never what we wanted. We want an outcome dashboard. We want to see, is it making a difference? Not, yes, you tick, you've seen X number of people, so what?
Thank you.
Brilliant. I'm conscious of the time. We're just coming up to 11:30. I just want to say thank you to everyone for participating and actually making this a really interactive session. A big thanks particularly to Lindsay for coming along and sharing her insights into the Frailty work. It's really fantastic. I hope people have found it interesting and insightful. Part of the reason why we're doing these webinars is because we really want to promote WSIC data. We really want to promote how it's used. We really want to sort of make sure that we get it out there, but we want to do that in a really helpful way. So we're going to take a little bit of time to sort of go through the comments and the feedback and sort of like the Mentimeters from the last 2 sessions and try and work through what we think we can do next that's helpful. But we really see this as the beginning of a dialogue rather than sort of we've put something out there, so please do get in contact with us. I put the link into the chat for the for feedback. Please take 5 minutes, let us know how the sessions have gone, what you would like to see next. We want to take this forward and we want to make sure that we're supporting to people to sort of use WSIC as much as possible. So on that note, I'm just going to say these were our learning outcomes. Please, when you're thinking about the when you're thinking about the feedback, have we met those outcomes? Are they the right outcomes that we wanted to do? What else would you like to see? Our names are here. So Rachel, the 2 Rachels, Rachel McCarthy, Rachel Christian, my names are listed here with our email addresses. Please do get in contact with us and let us know what you would like to see us do next, how we can be helpful. And on that, I'm just going to say thank you to everyone. Thank you, Lindsay. Thank you, Rachel McCarthy, and thank you, Rachel Christie. And apologies from Rachel Christie and I on our very, very poor internet access. And thank you, Rachel McCarthy, for saving the day and putting the slides up and taking us through. But most of all, thank you to everyone here. It's great to see so many people here. So thanks again. Have a great day.
Thank you too. Thank you.